All right, good morning, everyone. Welcome to our plenary session for Tuesday, September 26th. If preventing suicide is our target, suicide safe care in all healthcare settings is Bullseye. And I'm pleased to introduce in just a moment Dr. Michael Hogan. And Michael will be providing the information and the content on this plenary session. And as a couple of reminders and housekeeping things, while the speaker's presenting, you're going to be muted. We encourage folks to use the chat and Q&A areas for any questions. If possible, please try to refrain from the raise hand function. We will be holding all questions until the end of the webinar. These webinars are being recorded. You can find the recording posted on the platform for 30 days after the conclusion of the symposium. They'll also be added to the SPCNY website. Links will be shared with participants post-symposium. CEs will be provided post-symposium also once attendance is confirmed and an evaluation is completed by each participant. Evaluation surveys will be sent via email to all attendees. Again, all handouts are linked on the auditorium page next to each webinar link. And with that, I'm going to turn things over to Dr. Hogan.
Well, thanks, Gara. It's good to be with you virtually. It is still strange after 18 months or whatever it's been to talk to folks virtually, but we'll have a chance for a little conversation later. As I'll explain my background and where I'm coming from, and then I'll try to summarize what I'm going to present. As some of you know, I spent 5 years as OMH commissioner from 2007 to 2012, which followed 20 years of doing that in other states, Connecticut and Ohio. And about the time that I came to New York in 2007, I was starting to get seriously frustrated by our failure to make a dent in suicide, which had been increasing both in terms of numbers and rates of suicide. Ironically, since the publication of the first national strategy for suicide prevention. And so feeling that suicide was the worst case failure in our work, the worst outcome. I was frustrated about this, and this frustration led to a deep dive. I'm not a suicidologist. I hadn't really focused on that for most of my career, but it led to a deep dive to try to understand what might work. And that deep dive led to work with a whole bunch of other people to articulate or create this approach called zero suicide in healthcare. And I want to return to that theme of what's working and what's not working in this talk. And I'm going to make two propositions essentially that many people will perhaps disagree with, but that's fine. That the first of these propositions is that unless we increase our level of effort in what I would call upstream prevention or primary prevention, that is dealing with the root causes that ultimately may lead to suicide, unless we increase those efforts by, say, a factor of 10, they're unlikely to make a difference. And increasing primary prevention by a factor of 10 in this society, which is not particularly a political statement, but it's just unlikely. And so I'm not suggesting we abandon those efforts, but I am suggesting, this will sound a little cold, it's unreasonable to expect rates of suicide to decrease because of upstream prevention activities unless we really, really dramatically increase them. And my second proposition is that what now is proven to work is suicide prevention in healthcare settings, which has kind of taken off in the last 6 or 8 years. We have to remember that our focus on this, that the zero suicide model or approach, is really only about 8 years old. And if we really want to increase suicide prevention in healthcare, the focus should be on primary care, where many more people die. And when I say they die there, I don't mean they die in the office, but 43% of the people that die by suicide have seen a primary care practitioner within the month before they died. That's a rate a number that's twice as high as those who are in contact with behavioral health. And without disagreeing that primary care is already burdened, I'm going to argue that what I might label as suicide care in primary care is very similar to heart care. And heart care is very well established as a core primary care responsibility. We know what to do in primary care. We know when to refer people to a specialist. It's almost as if when it comes to suicide, we don't do anything except hope that people see a specialist. And I'm going to make the argument that we now have tools for suicide care in primary care that are effective. They're comparable to things that we now do to care for the heart. So the argument is, let's care for the brain the way we care for the heart. This kind of recapitulates that. So the field of suicide prevention is growing. We're now on our second edition of a national strategy for suicide prevention. And I guess probably the single biggest thing that's going on now that illustrates how that's growing is the national movement to designate 988 as a single national 3-digit number for mental health as well as suicide prevention. And that would have been unthinkable just a few years ago. So my focus here is what could turn the tide? What are practical, effective strategies that we could use? Just to reinforce again in the box at the bottom, the suicide deaths and actually rates of suicide death rose from 2001 to 2018. The rates were steady in 2019. They actually went down a fraction, but it was so small that it wasn't significant. And interestingly, rates of suicide declined slightly but significantly in 2020. And we still don't understand exactly why that was. It was during COVID, obviously, and we have some effort that in times that are tough for everybody, that there's people somehow want to hang around and support each other, and that may have contributed to this. But during that same year, rates of opioid overdose continued to rise dramatically. So it's certainly too early to declare victory when you have 45,000 people or more dying by suicide. In approaching healthcare problems, I would say in approaching any kind of healthcare problem, the most desirable thing that we can do is prevent the problem before it becomes a problem. What I would describe as upstream prevention. And I want to do a comparison here of an area where upstream prevention has been effective that I would argue is comparable to suicide prevention, and that is reducing deaths from cardiovascular disease by reducing smoking. And that has clearly worked. It's not that we've won that battle, but it's clearly worked. Rates of smoking have come down significantly, and rates of cardiovascular disease death have come down during this period. But if we think about the level of effort and what it's taken to do this, it's been a 50-year effort focus on reduced smoking. There have been over 30 reports of the Surgeon General on smoking and trying to reduce it among different populations, among youth, among elderly, and so on. We've got messaging that you see on every pack via big national campaigns. We've got a culture change that has led to laws that prevent smoking in public. Effective ad themes like the Marlboro Man are now can't be used, and there are, perhaps most importantly, significant taxes that have very dramatically raised the price of tobacco on every single purchase. And so that level of effort over a 50-year period has undoubtedly made an impact. Could we use that same approach for suicide prevention? And on the right-hand side, you see my analysis of this. First of all, addressing the significant underlying causes of suicide. And I don't mean just, I mean things that are really known to make a difference, like untreated trauma, untreated or inadequately treated mental illness and addiction, all of which we know contribute to suicide rates. Could we make a dent in those things the way we've made a dent in smoking? And my analysis is it's a pretty thought, but it's very hard to do. We have inadequate access to care as it is. A very significant number of people with mental health problems don't get care. The great majority of people with addiction problems don't have access to care. The treatments that we have are effective, but they're not cures. They're what we would think of in healthcare effectiveness overall as mid-range effective, as opposed to cures. And the needed investments are just not there. And so reducing suicide by, for example, curing depression is a very tough call for those reasons. And other similar big risk factors like economic insecurity or human pain and loss and isolation are very tough things to fix in our society. Now, we do have a little bit of evidence that comprehensive approaches to suicide prevention are effective. GLS is the Garrett Lee Smith Memorial Suicide Prevention Program that started in 2006. Garrett Lee Smith was the son of then Oregon Senator Gordon Smith, who died by suicide, and Senator Smith took it on himself to champion a national program for youth suicide prevention, which has grown to become these days about a $45 million national program. But it's a grant program, which means the grants are competitive. You compete for them. When you get the grant, you have it for 3 years or maybe 5 years. And the approaches to youth suicide prevention in Garrett Lee Smith have been evaluated and tracked pretty carefully. And the data show that in regions that have Garrett Lee Smith grants, the rate of increase in suicide is slowed or even reduced. And that goes on as long as the grants last. And the successes might persist. Recent data show that the successes might persist for a year or two after that, but basically shows the folly of trying to run a important prevention program on a time-limited discretionary grant basis, which means that at any point in the country, most of the population is not covered by one of these efforts. That's our biggest and most successful national suicide prevention program. So if we were to, for example, have a Garrett Lee Smith program, and I guess the other thing that I would say about this is the data on the GLS grants shows that the rate of suicide is reduced among the target population, which is young people aged 10 to 24, but not for the overall population. So, we'd have to make that truly national. We'd have to make it continuous. We'd have to expand it across the lifespan. which is probably a 10 or 20-fold increase. So looking at this comparison, I conclude that upstream efforts to prevent suicide, although they're very important, are woefully inadequate. And unless something really dramatic and unexpected happens, they're unlikely to affect rates of death in the next several decades. So that's led me to ask a different question, which is, okay, that it's going to be hard to change and dramatically increase investment in upstream prevention. But if we look at other causes of death where the rates are actually decreasing, are there lessons we can learn? And that's what I want to turn to. This is a somewhat dated slide. It's actually Dr. Jay Carruthers' slide, and it's dated in part because I'm not that good with PowerPoint, so I'm still using Jay's old picture here. But this shows death rates from 2003 to 2013 for some selected major causes of death. So here we see the death rate from suicide prevention, from heart disease, from stroke, from cancer, and this is all-cause mortality, the dark blue line in the middle, all causes of death. And so the question is, it seems pretty obvious that deaths from suicide prevention are working that well, yet deaths from heart disease intervention and prevention are working kind of well. What can we learn from that? So in any area of healthcare, we can think about three big buckets of intervention. I've just been talking about upstream health promotion. At the other end of the continuum, there's intensive treatment. For example, when it comes to heart disease, that would include valve replacements and stents and so on. And the thing about intensive treatments are that if we think about the success rate of valve replacements, it's very, very high. I haven't looked at data recently, but something like 80% plus effective. So it's very effective, which doesn't mean you want to run out and get your valve replaced if you don't need to. But if you need to get it replaced, there's a very good likelihood of a good outcome. And then in the middle are what we think of as preventive interventions. So preventive interventions involve identifying people who have risk of a bad outcome, not risk that is so high that they you rush out and, as I said, get your valve replaced, but the risk is high enough. So we ought to try to do something to take the edge off that risk. So, for example, in the area of cardiovascular disease, examples of preventive intervention are we see it every time we see a healthcare practitioner. You can scarcely bump into a nurse on the street without him putting a blood pressure cuff on you. So every single healthcare encounter, we measure our blood pressure. And if blood pressure is high, which is a significant risk factor for bad outcomes, we know what to do about that. And a lot of that is done in the primary care practice. We tend to not get over to the high intensity stuff unless the problem is very severe. The other good example when it comes to cardiovascular disease is, every time you have an annual physical, you probably get a lipid screen that looks at blood chemistry and identifies high cholesterol, which we also know is a risk factor for bad cardiovascular disease outcomes. And if we have high cholesterol, we're going to probably be asked to modify our diet. But even before that, we're probably going to be put on a statin to try to knock that down. And so this is examples of preventive interventions for those with identifiable risk. If we look at suicide, we've talked already about the challenges and how important, but also how difficult it is to resolve the problem through upstream prevention. If we go all the way over to the other extreme and look at intensive treatments for suicidality, well, we don't have anything that is, I would say, as effective as like valve replacement. The best outcomes for reducing suicide of any treatments are through dialectical behavior therapy, or DBT. It's maybe harder to get really good DBT these days than it is to get a valve replacement, which is, I'm not sure that that's true, but it's really hard to find access to high quality treatments for behavioral health problems. So we, just as with heart disease, we want them if we need them, but they're very hard to get. But the part that I want to explore is the part in the middle here. And the question is, can we identify, just as we can identify high blood pressure through a blood pressure screening, or high cholesterol through a examination of blood chemistry, can we identify those who are at risk of suicide? And then, even more importantly, are there things that we can do that are effective that don't involve getting that person into DBT for intensive treatment? And I'm going to make the point that we've now got evidence, almost all of it is within the last 5 or 10 years, that very brief, what I would describe in a way as small interventions, are quite effective in reducing rates of suicide. So I'm setting up here this notion that if we can do these activities of screening and then low intensity interventions for the heart, we got to be able to do the same interventions for the brain to prevent suicide, which obviously reinforces the notion that we ought to be working on suicide prevention in healthcare setting. It ought to be, suicide prevention ought to be an expected task in healthcare settings. This is some data from Brian Hamadani and the Mental Health Research Network, which is a national research network involving hundreds of thousands, actually millions of patients in many healthcare systems, including Kaiser and Henry Ford and Geisinger and so on. And they share their data for research purposes. And so Brian and his colleagues looked at that data and looked at the prior healthcare experience of people who are dying from suicide. And it turned out that over 90% of the people who made suicide attempts and over 80% of the people who actually died by suicide had healthcare visits in the prior 12 months. And many of them had contacts in the prior month. So you see 45% of the people who died by suicide had a primary visit in the month before they died. I was told by Yates Conwell, the suicide and geriatric mental health care expert at the University of Rochester, that among older men, this rate is over 70%. That is, over 70% of the older men who die by suicide had a primary care visit in the month before they died, which is kind of to me, a shocking number. And we can sort of see what the dynamics are there. And this is, just like trying to reconstruct something, but people are feeling pain. It's troubling enough to go see somebody about it. You're probably not in mental health care, and it wouldn't occur to you to go see one of us. But you have a doc that you've seen for years. You go see that physician who's got 10, 15 minutes, and suicide is probably not being screened for. And we don't have the words to bring up and describe this pain. We might describe it in somatic terms, and those somatic causes might be ruled out. But the visit is unlikely to lead to any intervention that deals with that level of pain, and then we can see what the outcomes are. And so we see other areas as well. 40% of those who die by suicide have an ED visit in the prior year. This is not necessarily an ED visit for a suicide attempt, because it turns out that accidents and other things that happen to people lead to an ED visit are correlated with the risks, or linked with the risks of suicide death. The very highest um, risk of suicide among any population anywhere in the world is among people who just got out of a psychiatric hospital, which is it's a paradox. You'd think that we were doing better with that, but we're still not at a point where we are responding to suicide risk, even in inpatient psychiatric settings. And so people go through the admission, they learn that they've got to say, I'm not suicidal, I'm not going to do that in order to get out, but they don't have relief. And we see this very high rate of death. So the looking at the data for the last 15, 20 years, if we go back and look at the data over 50 years, we see that the biggest single thing that's reduced cardiovascular disease deaths is reductions in smoking. But in the last 15 years or so, the biggest recent reductions haven't come from the upstream preventive activities. You just walk through the airport and you see that the messages about diet and exercise haven't taken place yet, and we've had many of the benefits from reducing smoking that we can expect. And while the intensive treatments are very effective, most people don't get them. And so it turns out that the biggest recent reductions have been from targeted preventive interventions for people who have been screened and have an elevated risk, whether it's blood pressure or cholesterol. So we identify it, and then we treat it. And the question is, could we do this for suicide? Which leads to really two other questions that I want to explore. One is, can we feasibly identify who has risk in healthcare settings? And the second is, do we have brief, inexpensive, effective interventions that can be used with these people? Now, some people are already thinking about the well-known, I don't even know what to call this, but the well-known proposition that we can't predict who's going to die by suicide, and ergo the notion is screening isn't worth it. And my question in response to that would be, can cardiologists predict who's going to die of a heart attack? And the answer is no, unless the risk is imminent and extraordinarily high. We can't predict who's going to die of cardiovascular disease, but we can predict who's got risk for it, and that leads us to do something. And so, if we follow that sort of nihilistic line of thinking, we could either, I guess several actions would be indicated. We could stop screening for blood pressure and statins, or we could start screening for suicide, because we can identify who's at risk. This is one study that demonstrated that. And this is Greg Simon and his colleagues. So you see, this is relatively recently, 2015. This was also data from the Mental Health Research Network. They actually had a sample for this study of actually about 80,000 people who had completed a PHQ-9, patient health questionnaire. Specifically, they looked at question 9, which is the suicide question on the PHQ-9. And what they looked at very simply was whether people who subsequently died by suicide had said they were thinking about it. And the answer is that 80% of the people who died by suicide in this sample of 80,000 people had said at the time they filled out the PHQ-9 that they were thinking about it. So this is a very high positivity rate, which leads to this conclusion: in the screening to identify the need for suicide intervention. This is the same logic as for heart disease. So we're screening to find out if a preventive intervention would be useful. Is as effective at screening for cardiovascular disease intervention by looking at lipid levels or blood pressure. And so that leads to a pretty common sense conclusion, which is we should use evidence-based brief screening tools throughout healthcare. Now, we've kind of started to do this in behavioral health settings. As a matter of fact, the Joint Commission now requires for hospitals, critical access hospitals, and behavioral health organizations, suicide screening for every person who's under care for a behavioral health condition or who has a behavioral health diagnosis. They haven't yet gone to the place of universal screening just because of the lag time in culture change. They didn't want to introduce a requirement that, in a sense, the field wasn't ready for yet. But we're doing the screening now in behavioral health settings. Again, we're not doing it in primary care. But the question that gets raised is, do we have interventions that are feasible and effective if somebody is identified as having suicide risk? And if somebody is screened as having suicide risk, in the vast majority of situations, that risk is not so urgent that sending them straight to inpatient care is needed. People are generally not saying, I've thought about dying. I want to end my life. I know how I'm going to do it. I have a plan, and I'm going to do it soon. With that kind of acuity, we would want to probably both contain and treat people to keep them safe and to resolve the situation. But for the vast majority of people, it's going to be some thoughts about suicide. It's a nagging kind of problem. It's out there. They may have thought about means. They don't have a plan, and they don't have intent to die. And so one of the interventions, thanks to colleagues at Columbia, Barbara Stanley and her group, and Greg Brown at Penn, we have the safety planning intervention, which is a one-session intervention that it might be described in a way as a one-session CPT effort to give people the skills and tools to keep themselves safe and to help them recognize when these feelings are coming on, and to have a toolkit about things they can do themselves, actions they can take that involve others, or steps they can take to keep themselves safe in that eventuality. And the study, I say here, I didn't put a citation in this. I think this was 2019 by Barbara and Greg, a really big study done in Veterans Administration emergency departments. So this wasn't in psych settings, it was in EDs. And they had a sample of 2,700 people, some of whom were put in a protocol that basically included usual care, which is a referral for follow-up care, plus two things. The safety planning intervention before they left the emergency department that day, and a couple of follow-up phone calls. And these are the data from that real-world study. There was a 45% reduction in subsequent suicide behaviors, which basically is attempts. And interestingly, the people who got the follow-up call were twice as likely to participate in follow-up treatment, which reflects a paradox. The paradox is that people who are experiencing suicidality are actually less likely to agree to follow-up care than people that are not. Less likely. Their experience hasn't suggested to them that it would be useful, probably. Or maybe they're worried about being hospitalized or whatever it is. But it's a dramatic finding that we can double the chance that people will participate in follow-up treatment. And to just note that the effectiveness of this linked intervention, the safety planning intervention, and an average of 2 follow-up phone calls, is on average better than that for statins if we measure the outcome of statins as preventing a myocardial infarction or heart attack. Now, the last time I looked, we spent about $30 billion a year annually on statins internationally, which is so far beyond the spread of these brief interventions to suicide prevention. But we have this paradox of feasible, brief, and effective interventions that are not now being adequately used. The second intervention was included in the last slide, and this is what we started to call caring contacts. This is actually the one area where research has shown effectiveness over a long period of time. This goes back to psychiatrist Jerry Motto's study in San Francisco, I think in the 80s. And the study was breathtaking. It involved randomized groups of people being discharged from inpatient psych settings. The one group basically got a referral, which is what you usually get. Another group got a referral, and then they got handwritten letters from people at the hospital, I think once a month for the first few months, and then tapering back a little bit. And the letters were not like, you have an appointment, please come in. The letters are more like, we hope you're doing well. We remember when you were with us, and you made good progress. We hope you're taking care of yourself. If you have any concerns at all, or if we can do anything, please let us know, and we care about it. And the intervention of the caring letters resulted in a 50% reduction in deaths in this study. And these results, although not necessarily as dramatic, have now been replicated for follow-up phone calls, as in the Stanley and Brown study, text, postcard, basically any kind of human contact turns out to be effective in reducing suicide attempts and suicide deaths. And in a sense, it's not surprising, because isolation is the poisonous environment within which suicidal thoughts ferment. And as well as following, Thomas Joiner's model of suicide, followed by the perception that you're a burden on others, and people might even be better off if you weren't around. So the intervention of a letter, a postcard, any kind of a caring, low demand follow-up, it strikes directly at this pernicious problem of isolation. So caring letters are very effective as well. And so these simple ingredients are the core elements of zero suicide. But of course, zero suicide also focuses on the more intensive treatments for people that have more complicated needs, as well as other elements of training and leadership and evaluation, so on. And so if we take that background to think about how we're doing with suicide prevention in healthcare, and basically wherever zero suicide has been implemented and evaluated, the results have been very good. So this is just a summary of that data. There aren't any randomized controlled trials yet. I don't know whether it'd be ethical to do one for the full model, because we now have a lot of data that it works. But the National Institute of Mental Health has funded a number of studies that look at the components of zero suicide. What we do know is that rates of death among people in usual care are unacceptably high. And basically every place that has implemented the full tilt boogie approach has had positive results. The real inspiration for all of this was at Henry Ford Health System, and you will have heard Dr. Coffey describe those efforts. Those results were so spectacular that basically the field of suicide prevention didn't believe them. This was the most effective suicide prevention the world had ever seen. And what was interesting is it didn't really start out as a suicide prevention program. It was an effort to try to deliver, if possible, perfect care that led to measuring suicide, because that would be a core indication of whether care was perfect. And so in this program, we had over 75% reduction in suicide rates among a population receiving mental health care, or to put it differently, levels of suicide in a population under psychiatric care were reduced to the general population level. Center Stone in Tennessee is a big mental health operation. They achieved a 65% reduction over 3 or 4 years, results that are very similar to Henry Ford. The Institute for Family Health, going back a few years in New York, documented a 65% reduction in integrated primary care settings to a level of about 2 deaths per 100,000, which is a tiny fraction of the overall suicide rate. And then there are several other examples here. The New York study people may not have heard about, but OMH a few years ago through the Psyches program did a Medicaid quality insurance, a quality improvement project focused on suicide. And the data from this were just interesting. At the beginning of the project, all the clinics completed the zero suicide self-assessment, which is just a measurement of basically how are we doing on suicide care. And the finding here was that the suicide rates in clinics with a higher self-assessment score, that is better suicide care, were significantly lower than deaths in clinics that weren't doing that. So we do know that this zero suicide looks quite effective, but it's still brand new. It's only 6 or 8 years old. I think it's dramatically changed practice in behavioral health care settings, and that's been encouraged by states. New York has encouraged it, but also by SAMHSA grants and CARF requirements. But only a small percentage of people who die by suicide are people getting behavioral health care. Many more, 4 times as many people who die by suicide were not getting behavioral health care, but they had an ED visit or a primary care visit. As I said before, the Joint Commission has stepped up in this regard, but primary care is basically not on board with this yet. And it's an easily understandable but sad paradox from my point of view. Care for the heart is very well established as a core primary care responsibility. When we know what the internist and the internal medicine office is supposed to do, and we know what the cardiologist is supposed to do, and the lines of referral and care between the two are pretty clear. But the care for the brain isn't that well established. I'm thinking about the first primary care doc that I had a significant conversation with about this. It was the first time nationally, I think it was 2014, that we did a sort of a zero suicide boot camp, and we had somehow it was almost all behavioral health people, but there was one internist from a relatively small practice who somehow got into the room. And I was really curious on his take on this challenge. And so I, edged over to him partway through the training and said, "So, what do you think about this?" And he said, "Well, here's what I'm learning. I use a PHQ-2 in the waiting room as a screener. And one of the things that I've learned is that relying on a first identification of a behavioral health problem and then going on to look for suicide is going to miss a lot of people. Not everybody who dies by suicide was depressed. About half the people who die by suicide didn't have a diagnosed behavioral health problem. Now, a lot of that was because they hadn't seen anybody, or they had a condition that hadn't been diagnosed. So he went on to say, the first thing I'm going to do is talk with my people, and we're going to add that question 9 on the PHQ-9 to the 2-question PHQ-2. We'll have a PHQ-3. And he said, we'll do that in the waiting room. And he said, based on what I'm hearing, I think the risk of suicide is about the same scope as the risk of prostate cancer in my clinic. And so that means that the vast majority of people are not going to have risk, and I'm not going to pay attention to it. Let's say it's 1 or 2% are going to screen positive. But one of the other things that I'm learning is that if they screen positive, if they have that risk, that's going to become the focus of that visit that day for that patient. And I'm going to spend time with them, try to help them understand this, then I'm going to make sure that they get follow-up care. It's not going to be just it's just a referral. And I thought that answer was indicative of where the primary care field should be, but it's not there yet. And I'm encouraging people, particularly in primary care, and especially in primary care, where there is some capability for integrated care, that is, behavioral health people are in the practice. From my point of view, there's no reason why suicide care shouldn't be in scope. And so, concluding the talk, I'm going to just sum up here. Until we can make really dramatic changes in beliefs and policy investments that would take us from 0 to 60 in terms of upstream prevention, that if we really want to save lives from suicide, the best thing we can do is to make healthcare suicide safe. There are some people that are working on this strategy. The American Foundation for Suicide Prevention Project 2025 focuses on healthcare, and both CARF and the Joint Commission have stepped up just in the last couple of years to require improved suicide care. There are early signs of broader change, for example, 988, but this is going to take a long time to emerge and show. In the short run, I would argue that if we want to save lives from suicide, broader encouragement and action that focuses on suicide-safe care, especially in mainstream healthcare settings, and most especially in capable or integrated primary care, is our best bet. And I would advocate that would be the single most feasible, effective action we could take to reduce rates of suicide. So with all that, thanks for listening. I'm going to stop the screen share thing here, and I think Agara is going to moderate conversation. So if you have questions, whether it's in chat or on the Agara, you can tell people how to do it.
Sure. Thank you, Dr. Hogan. Thank you for that amazing, compelling, and ultimately hopeful presentation in terms of suicide safer care and healthcare. We do have one question that's popped up already regarding the New York Psyches Project. What do you think that means for providers when self-assessment scores are higher, means that patients get more specialized attention, is the question?
This is going to be a little blunt, but I think it means that the practice is paying attention to suicide. And but paying attention to it means there really is no, a screening is certainly not an adequate assessment of risk. But it is probably the only feasible way to uncover risk in many individuals who are not likely to bring it up otherwise. And so first, it means that practices that score higher are probably screening. There were actually two specific elements on this. I may be getting to the weeds here, but I think it's pretty relevant. There were two specific elements or specific questions on the organizational self-assessment that in this big New York study turned out to also be significantly related to reduced suicide. One of those was a question about reducing means. And it's logical, but it's also notable because everybody that has tried to do this work has reported that really significant efforts to reduce lethal means, not just as a general community-wide activity, but as a specific intervention for people who indicated that they were thinking about suicide, is one of the most effective things that could be done. So, Dr. Coffey has talked about in the Henry Ford experience, the staff there learning from a quality improvement perspective that this was useful. And so that led to things like, asking people during the visit, do you have a weapon at home? would it be okay if we called home now and if anybody's home and had that weapon be stored in a safe place until you feel better, then to make the call, and then to call back later and validate that the action was actually taken, and then to follow up on the next visit. So this one question that asks about practices to reduce lethal means for people that are at risk also was significantly correlated with outcomes. And interestingly, the other question that correlated significantly with outcomes was whether the clinic was carrying out quality improvement activities specifically related to suicide care. There's not just a general quality improvement program. So this might include, things like, are we actually screening people? When people screen positive, do they get an assessment? When we have concerns about people's risk, do they get a safety plan completed before they leave that day? Are the safety plans any good, et cetera, et cetera? So my overall response here was that the big thing is that these clinics were paying attention to suicide. And those are two examples of specifics that came through in the data.
Thank you. I'm not seeing at the present any other questions in the Q&A or chat function, but want to make sure that folks have an opportunity to ask any questions right now before in the next few minutes we'll be transitioning over to the structured panel Q&A. See another question that came in, just an acknowledgement, thanking you for the presentation and that it was awesome.
Well, that's a very kind, Maura. Thank you for that. The real payback, of course, will be what you all do with this. It's hard work, but it's life-saving work. And I think also that you should be aware that in New York, and this conference is an example, but through the Suicide Prevention Center, through the team at Columbia that has developed the whole AIM approach for suicide prevention, the resources that are available to assist in this work are better than they are in any other state. So it's still very, very hard work, but the resources are there to carry it out. So I hope that you do. I hope if you're in a setting that's now doing that, I hope this reinforces the importance of that work. And if you're in a setting that's not doing that work, I hope to go back and start a conversation about what it might be feasible and appropriate to do in your clinic.
Really great to know that we don't have to be in this work alone and that there are tools and resources that are continuing to develop. So for folks who are beginning this work or someplace along the continuum, there are resources there. Seeing anything else coming through? So just as a reminder, there's going to be a structured panel Q&A coming up at noon with Dr. Hogan and Dr. Coffey. And so we, without any further questions or comments, we hope to see everyone there. We'll give you 5 minutes to stretch your legs and fluid level adjustments. And thank you again, Dr. Hogan. Appreciate the content and the hopeful message of suicide safer care in healthcare settings.
Thanks, Gara.